Hello guys, welcome to our Sureshot series. Today we are going to discuss about the another former topic, anti-diabetic drugs. This is also one of the most important topic. At least 2 to 3 questions are repeated in NEETPG and FMGE examination. Before we start the discussion, please do subscribe to this channel and also share with your friends. Soon we are going to upload the expected topics of FMG July 2025 into 3 parts and also revision classes of the internal medicine and different subjects. Before anti-diabetic drugs, I want you guys to understand what is the difference between the diabetes mellitus type 1 and diabetes mellitus type 2. Here you can see the picture. The diabetes type 1 is only that this is not a insulin resistance instead of insulin absence. Okay, the insulin itself absent. Why this is? This could be due to any environmental factors or any viral infections. Mostly this is seen in the younger individuals. Okay, since the insulin is completely absent, what we can do, mostly these people will be needed the injectables as a treatment. Okay, oral drugs is not going to suffice this patient. Completely the insulin is absent in the type 1 diabetes mellitus. What about the type 2 diabetes mellitus? Here you can see the insulin presence is seen. There is no absence of the insulin, but what happening here, there is a resistance. Okay, there is a resistance to uptake of the insulin. And what we can give the oral hypoglycemic drugs, and we can give the patients as a diet changes or the lifestyle changes. Okay, what could be the cause of type 2 diabetes mellitus? Simply obesity, okay, genetics and sedentary lifestyle. And if type 2 diabetes mellitus is progressed with the complications, then we can start the patients on the injectables. Let's look at the different classes and their examples, mechanisms of action, and the key points of each drug. Okay, let's start with our first discussion is the bigonides. But commonly, the drugs which is known for the bigonides is your metformin. Okay, and what is the specialty of the metformin? This is the drug of the choice for type 2 diabetes mellitus. Okay, this is a common question, and worldwide the commonly used drug for the first line of the treatment for the diabetes mellitus. And what is the mechanism of action for the metformin? It will decrease the gluconeogenesis. And it will decrease the glycogenolysis. And the best thing is it will decrease the insulin resistance. And the other things are, it will decrease the LDL. And the key points to take note when we are giving the metformin, the main thing is we are preventing the micro and macro complications in the patients. And there is a side effects that take note. It will decrease the vitamin B12, causing the anemia, and it will cause the lactic acidosis. When the patient is having the less than 30 glomerular filtration rate, this is the completely contraindicated in the renal failure patients. The metformin can be given for the patients of PCOS as well. Sulfonylureas. These are also the commonly used drug, but nowadays due to its high hypoglycemia chances and the weight gain, these drugs are less used or less doses commonly used. What are the examples of the sulfonylureas? Glimepiride or the glibroid. All the drugs will start with the gly or the gly, which will be commonly seen in the sulfonylureas. What is the mechanism of action? Commonly, this will block the potassium activated ATP channels, and this will further increase the calcium channels opening, and exocytosis of the insulin will be seen, and it will increase the insulin secretion. And what are the things that you have to remember for the key points of the sulfonylureas? There is a high chance of weight gain in the patients and high risk of the hypoglycemia chances is seen in these patients. All these things to be take noted when we are giving the sulfonylureas, and it is completely contraindicated in the patients of the heart disease. Next, moving on to the meglinotides. The common drugs are your natiglitide and your rapaglinide. Okay, the drugs which will end with the glinides, those are your meglitinides. And what is the mechanism of action? Same as the sulfonylureas, it will block the potassium ATP channels, so thus it will increase the insulin secretion. But what is the same thing that is different from the sulfonylureas? It will be having the faster onset and it will be having the shorter duration, so it will cause the less chances of the hypoglycemia in the patients, but still it will be having the weight gain issues in the patients. So these are your meglinoids. So before we discuss about the DPP-4 inhibitors, I want you guys to understand about the GLP-1 receptor agonist. Where this GLP-1 agonist will be working, guys? GLP-1 agonist is your increase the incretins functions. What this incretins will do? Indirectly, this will increase the insulin secretion. How this is going to increase the insulin secretion? By decreasing the satiety and by decreasing the gastric emptying. These drugs, and the name itself telling that GLP glucagon like peptide 1. So this will decrease the glucagon secretion and increase the insulin secretion in the body. So thus these drugs are very widely used and very beneficial to the patients. The one thing that should be taken note, these are given as a subcutaneous route. What are the examples of your GLP-1 agonist? The drugs that you have in the market is your semaglutide, the famously known drug. This is your Ozempic drug, and another one is your dulaglutide. And one thing that we should remember about the dulaglutide, this is completely renal safe drug. And next, what are the key points that we have to take note about the GLP-1? These are the best drugs for your weight loss, and these can cause the pancreatitis in the patients, high risk, because the incretins function is seen in the intestines. We have the special drug in the market, GLP-1 and the GIP-1, the combination drug, that is your tirzepatide. This is used for the weight loss and the diabetes mellitus. And next, we are going back to the DPP-4 inhibitors, and the commonly what these DPP-4 inhibitors will do, DPP-4 enzyme will do, this will decrease the GLP-1 or the GIP action. So that's why we are going to block this DPP-4 with the inhibiting this DPP-4 enzyme. What are the drugs we have here, guys? That is your sitagliptin, all the gliptans, that is your sitagliptin and the linagliptin. And the other thing that you have to remember of the linagliptin, this is the completely renal safe drug in the patient. Why? L for linagliptin, L for liver, this is excreted by your liver. This is the mechanism for the DPP-4 inhibitors. It will increase the GLP-1 in the GIP-1 action. So thus it will decrease the gastric emptying and it will increase the insulin secretion in the body, and will also decrease the glucagon secretion. All right, next, what is the key points that we have to take note for the DPP-4 inhibitors? It is completely contraindicated in the renal failure patients, but again the exception is linagliptin can be given, and it can also cause the pancreatitis, and this does not cause the weight gain or the weight loss. It will maintain the weight neutral in the patients. And next, moving on to the SGLT2 inhibitors. This is the most widely used drug in the congestive heart failure patients. In the kidneys, when we inhibit the SGLT2, this will cause the glucosuria. And what are the drugs we have? The SGLT2, canagliflozin and your sotagliflozin. And how this is going to helpful in the congestive heart failures? Because when we block the SGLT2, this will cause the increase the glycosuria, and more urine will be excreted from the body. So thus this will decrease the fluid overload in your body and helpful in the congestive heart failure patients. And what are the things that you have to take note? This will cause the UTI and the vaginal infections commonly in the older patients. And completely safest drug for your congestive heart failure patients, and this can also cause the weight loss for obesity patients. But there is a study that showed the canagliflozin is associated with the fractures of the body. And next, we are moving on to the amylin analogs, pra-amylintide. Okay, this is the only drug available that can be given as a subcutaneous. And what is the specialty of the amylin analogs? There is a hormone present on the beta cells, which will increase the insulin secretion and decrease the gastric emptying. And it can be used in the type 1 patients, and also it can be used in the type 2 patients because it is given as a subcutaneous. There is a risk of hypoglycemia only if we use along with the sulfonylureas or other insulin injectables. And most common side effect is nausea and vomiting. Next, moving on to the alpha glucosidase inhibitors, and we have commonly the drugs are your voglibose, meglitol, and the acaribose. Mechanism for the alpha glucosidase will delay the gastric emptying, and this will delay the conversion of carbohydrates. So thus there will be a less glucagon release, and there will be a glucose absorption is also decreased. But the high chances that the patient can be having the diarrhea and the GI upset. But patients, those who are suffering from the inflammatory bowel disease, these drugs are contraindicated. And other side effects, you can see that the patient can have the flatlines and the last class, that is your thiazolidinidones. And what are the drugs we have? That is your pioglitazones. What is the mechanism for these pioglitazones? It will activate the peroxisome PPAR gamma. So this will activate this enzyme, and this will cause the increase the muscle and the fat absorption by the glucose. So the GLUT4 will be opening, and the more and more muscle and the fat will be adapting the glucose uptake, and will indirectly it will decrease the gluconeogenesis by the liver. And these are the safest drugs for your renal failure patient. But there is a high risk of the osteoporosis and the high risk of the weight gain in the patients. So that's why this is contraindicated in the patients those who are suffering from the congestive heart failure. And there is also a study that found that pioglitazone can cause the bladder cancer. And always remember that focus on the high yield topics and the previous year topics. Please do subscribe to our channel and join the Telegram and WhatsApp channel for more content. Thank you.